Good afternoon, everyone. I thank the organizers for inviting me for this talk. I'm really sorry not to be with you live because I have a commitment. So today I'll be talking to you about recent advances in esophageal cancer. My name is Ahmed Magdy. I'm a lecturer and consultant of medical oncology in the National Cancer Institute, Cairo University, and the director of medical oncology department in Shifa Al-Orman Hospital, Luxor. These are my disclosures for today. I'll give you a few seconds to look at them. And this is my agenda for today. I'm going to give you a brief introduction, how to diagnose the cancer esophagus, how to manage, and to conclude my talk. So to start with, the esophagus, according to the Global CAN in 2020, represents only 3.1% of the incidence of malignancies in both sexes, actually. And for the cause of death, it's really around the fifth or sixth cause of death. Of course, number one is lung cancer. And if you look from the global CAN perspective, in Egypt, actually cancer esophagus is the number 16 in incidence and prevalence of cancer. There are also some anatomical special characters that we have to put in mind when we are looking at cancer esophagus cases. Number one, the esophagus lacks a serosa, which allows it to directly infiltrate the surrounding structures. Number two, we do have two different types of muscles. We do have the striated in the proximal third and smooth in distal third. And this again explains why we do have different pathologies in cancer esophagus. Also, we have two different types of epithelium, and we do have segmental blood supply. This is why we do have the upper, the middle, and lower esophagus anatomically differentiated. Even the management is different. So we do have a number of risk factors for squamous cell carcinoma. Of course, we do have the alcohol and tobacco smoking, the male gender, the Plummer-Vinson syndrome, tylosis, achalasia of the cardia, Fanconi anemia, caustic ingestion, and ALDH2 deficient gene, which is more common in Eastern countries like Japan, because this enzyme is responsible for the metabolism of alcohol. So the deficiency of this enzyme, leads to this gene leads to the higher incidence of cancer due to alcohol ingestion. For the adenocarcinoma, we do have the Barrett's esophagus, the Zollinger-Ellison syndrome, smoking, again, male gender, and obesity. So for pathological classifications, we do have some subtype of pre-invasive tumors and invasive tumors. So as I mentioned before, from some of the facts mentioned, that it is a heterogeneous malignancy and it's not one malignancy in the esophagus. So for the pre-invasive tumors, we do have the esophageal intraepithelial neoplasia and adenocarcinoma in situ in Barrett's mucosa. But for the invasive tumor, we do have the squamous cell carcinoma, adenocarcinoma, adenoid cystic carcinoma, mucoepidermoid, a mixture of adenosquamous, small cell carcinoma, or sometimes the carcinoid syndromes, neuroendocrine neoplasms, melanomas, and rarely sarcomas. So for the esophageal squamous cell carcinoma, it's more common, again, in the Eastern countries, in Asia and Eastern Europe, while the adenocarcinoma is more common in the Western countries like North America and West Europe. How to diagnose? Of course, we do have symptoms and signs that the patient complain of, like dysphagia, frequent choking on food, weight loss, vomiting, GERD, coughing and hoarseness, and symptoms of metastasis. For example, like the patient may present with jaundice. This is due to liver metastasis, dyspnea, which is due to lung metastasis, maybe a fractured bone due to metastasis in the bones. So the investigations of choice, of course, number one, the upper GI endoscopy, endoscopic ultrasound, which actually makes staging easier, for the T staging mainly with the TNM staging. PET-CT is done only if no evidence of metastasis. So if you do your investigations and you think the patient is candidate for surgery, then please proceed with PET-CT, and it's recommended in the guidelines to rule out any metastatic sites. Bronchoscopy, if only the tumor is at or above the carina with no evidence of M1 disease, because we need to see if there is a T4 invasion. Also, we must do molecular studies, but this is only in metastatic cases, which is the microsatellite instability by the PCR or the MMR, PD-L1. Why? Because now we do have anti-PD-L1s, which are the immunotherapy or the immune checkpoint inhibitors, which targets the PD-L1 overexpressed tumors. And also the HER2. The HER2 is a type of growth receptor which is well established in breast cancer, but recently by a trial in the gastroesophageal malignancies, it was found out that sometimes it's overexpressed, and actually we do have some targeted therapies regarding the HER2, which I'll speak later about. Also, we need to do full labs to assess the patient, kidney functions, liver functions, and the anemia. For the tumor markers, yes, we do need to do it, which will be the CA19-9, but we don't depend on tumor markers in our diagnosis because they are non-specific. So this is a picture of the PET-CT, which shows you that when you do the barium follow-through, there are some restrictions. And then when you do the PET-CT, you see the hyperactive lesion present in the esophagus, which is the one illuminating in orange, as you can see, or yellow. The brain, of course, in the PET-CT is always lit, and the bladder. So this shows you the staging of esophageal cancer, and according to the TNM and according to the AGCC staging system. So now we're going to go to the management of gastroesophageal or esophageal malignancies. As we all know, and of course I'm speaking with the experts here, that we do have the endoscopic mucosal resection, but these needs a highly specific population of patients. For example, you need a T1A or superficial pathological T1B tumors that are less than or equal 3 centimeters in diameter, and these are the best for the approach with the endoscopic mucosal resection. And they should not have a lymphovascular invasion, because in general, in cancer, when you see the lymphovascular invasion, it would mainly relate to an aggressive type or maybe a high risk factor for the malignancy you have to consider and put in mind in every type of cancer. And of course, the patient must not have a poorly differentiated histology, which is the grade 3. Why? Because usually they are very aggressive and they do have a hidden metastasis or micrometastases. So the concept for the management surgically is just removal of the segment of the esophagus and maybe the gastroesophageal junction, and we do a gastric pull-up, and the esophagus is joined to the stomach. This is broadly speaking. So as I mentioned, we do have two types of pathology, the adenocarcinoma and the squamous cell carcinoma. So for the esophageal adenocarcinoma, we do have many clinical trials, actually the preoperative management. So in general, in gastroesophageal or esophageal malignancies, the neoadjuvant, which is giving chemotherapy or chemo and radiotherapy before surgery, is a mainstay in the management. So whenever we see an esophageal or gastroesophageal malignancy, we have to discuss with the radiotherapy and chemotherapy before proceeding with surgery. And yes, we do have evidence for that. I'll show you. For the adenocarcinoma, the preoperative chemoradiotherapy for esophageal or junctional cancer has shown that the median overall survival was markedly improved. As you can see, 48.6 versus 24 months, with a good hazard ratio of 0.68 and a statistical significance. And if you look here down on the B figure, you'll find that the benefit is more with the squamous cell carcinoma rather than the adenocarcinoma. But both of them benefit from concomitant chemoradiotherapy rather than surgery alone. And if you look at the subgroup analysis, you will find in this forest plot diagram that all are in favor of the chemoradiotherapy and surgery better than surgery alone. Also, there is the famous MAGIC trial, which we as oncologists have been following for the past 20 years, actually. It is for the adenocarcinoma. They randomized patients to preoperative regimen called the ECF, which is a 3-drug regimen of chemotherapy, followed by surgery, then followed by continuation by 3 cycles of the same regimen, or we go straight ahead to surgery. And if you look at the curves, definitely you'll find a better overall survival with chemotherapy as before surgery, with a 36% 5 years overall survival rate versus 23%, with an acceptable hazard ratio of 0.75 and statistically significant p-value. Then recently, as you can see here in 2019, came the best or the excellent regimen, the FLOT4 regimen, which is a 4-drug regimen, and it was compared to the 3-drug regimen used before in the MAGIC trial. And again, for this clinical trial, it had the same as the MAGIC trial. So we give the FLOT times 4, followed by surgical resection, followed by the FLOT again by 4 cycles. So the FLOT includes the docetaxel chemotherapy, 5-FU, calcium leucovorin, and oxaliplatin every 2 weeks versus the regimen for the MAGIC trial. And of course, there is a marvelous response with a median overall survival of 50 months versus 37 months with an acceptable hazard ratio. And this regimen, on personal basis, I've used it in many patients, and the response was excellent. And the patients are in complete CR even after surgery with no evidence of recurrence. However, there is a caveat here because this is a 4-drug regimen, so it is very toxic. And as you can see here, the grade 3 or 4 rate of infections are higher than the ECX. Neutropenia is high, and diarrhea is higher, of course, and peripheral neuropathy. Although the rate of pathological CR, meaning that after doing the surgery, there is no evidence of malignancy in the specimen, it was a little bit better with the FLOT regimen. However, please take care. FLOT is only for patients with good performance status and who can tolerate this highly toxic regimen. So you need a young patient with a good performance status who can tolerate, and proper follow-up for your patients and protection against infection. What about squamous cell carcinoma? So now we've talked about the adenocarcinoma. Is there any difference in the management of squamous cell carcinoma? Let's see together. So there's the famous GCOG clinical trial, which was randomized for post-operative adjuvant chemotherapy with cisplatin and 5-FU versus the pre-operative, which is neoadjuvant. And yes, you can see that there is an improvement in progression-free survival and also in overall survival with a statistically significant p-value. As you can see, 60% versus 38.4% just by giving the chemotherapy before the surgery. Also, there is another famous clinical trial published in 2007 actually tackling if we gave chemoradiation followed by surgery, compared to chemoradiation alone in squamous cell carcinoma. And actually, this is the trial design, which showed that there is no difference between giving chemoradiotherapy versus surgery. Hence, now in squamous cell carcinoma, it could be recommended that you give concomitant chemoradiotherapy and put your patient under follow-up without subjecting him to the risk of post-operative complications. So according to the National Comprehensive Cancer Network, which is the most recent guidelines just accessed 4 days ago, this shows you these are all the principles of systemic therapy in newly diagnosed cancer esophagus. As you can see, we do have lots and lots of regimens, but we only follow the category 1 because they are the highest evidence of them all. What about the metastatic esophageal cancers? So here are some facts regarding the metastatic disease. So a 2-drug regimen containing either oxaliplatin or cisplatin is recommended, and only the 3-drug regimen is reserved to a subset of patients that can tolerate it. So no need to give more chemotherapy in a metastatic case, which is somehow is a difficult case to approach. So you don't need more toxicity with triple chemotherapy. And as I mentioned before, molecular studies are mandatory because now we do have something called the targeted therapies, and immunotherapies in cancer esophagus. Also, the HER2 overexpression, which is very well established in breast cancer, occurs in around 7 to 34% of gastroesophageal junction adenocarcinoma. So we have to look for that because we do have a targeted therapy called the trastuzumab, and I'll show you in the coming slides. So this trial was published in The Lancet, which is the TOGA trial, the famous TOGA trial, looking at the HER2 overexpression in gastroesophageal junction and gastric carcinomas and targeting this HER2 mutation or overexpression, sorry. So for the TOGA trial, they got advanced gastric and gastroesophageal carcinomas, and they compared it to a 2-drug regimen of 5-FU and cisplatin versus 5-FU, cisplatin, and the trastuzumab targeted therapy. And it showed actually a median overall survival of 16 months versus 11.8 months. So it really affects the overall survival. And yes, we have to use this targeted therapy in gastroesophageal junction carcinomas. And if you look at the progression-free survival, yes, it was statistically significant, although some of you will say it only affected the median overall, the median progression-free survival by 1 month, but the overall survival, as you can see, was improved. Then came another player, which is a drug called the Cyramza, which is an anti-vascular endothelial growth factor targeted therapy in combination with chemotherapy. So for the ramucirumab in combination with chemotherapy versus placebo and chemotherapy, it showed actually a progression-free survival difference of 1.4 or 1.5 months actually, which was statistically significant. But however, it came with a lot of toxicity. So there was the other regard study using only the anti-VEGF or vascular endothelial growth factor targeted therapy, the Cyramza or the ramucirumab as single agent versus the placebo. Yes, it gave a difference of progression overall survival of 5.2 months versus 3.8 months. Yes, it's very low, but in a very advanced disease, very aggressive with limited treatment available, then this is somehow something, and maybe that in the future, in another proper combination, we can use this medication to improve the survival. So now we're in the era of the immunotherapy. So we do have the anti-PD-L1s or the PD-1s. So nivolumab is one of the immune checkpoint inhibitors or the immunotherapies, was compared to chemotherapy in the ATTRACTION-3 trial. So patients who were refractory, as you can see, or intolerant to prior fluoropyrimidine, which is the 5-fluorouracil and platinum-based therapy or cisplatin, they were randomized 1-to-1 to nivolumab, which is anti-PD-1 immunotherapy versus chemotherapy of whatever the mainly was the docetaxel, chemotherapy, and patients were on the treatment till progressive disease or unacceptable toxicity. And if you look here, the overall survival was in favor of the nivolumab at 10.9 months, almost 11 months versus 8.4 months, with a hazard ratio of 0.77. And the duration of response was actually maintained with the nivolumab of 6.9 months duration of response versus the chemotherapy at 3.9. And the progression-free survival, actually, chemotherapy was better in this clinical trial. However, one of the major toxicities of nivolumab is the autoimmune components. So when we give the immune checkpoint inhibitor, sometimes we overstimulate the immune system of the patient, leading to pneumonitis, hepatitis, dermatitis, whatever autoimmune reaction can occur. And also one of the major side effects of using immunotherapy is the price. So nivolumab costs per month around 40,000 Egyptian pounds. This is with the every 2 weeks, So, and this is with something called the patient support program. So in general, it costs about around 80,000 pounds, Egyptian pounds, every 2 weeks. Then there is another player, another famous player in the immunotherapy landscape is the pembrolizumab, which is one of the, again, also first immunotherapies to be developed. So a safety and efficacy of pembrolizumab monotherapy in patients with previously treated gastric and gastroesophageal junction. As you can see, there is in this waterfall plot, it shows that there is a 30% decrease in tumor size for heavily pretreated patients before, and the duration of response is actually prolonged for those patients. So if you look at the guidelines, we do have, again, this is the most recent guidelines accessed again 4 days ago, you'll find that the trastuzumab, which is the anti-HER2, is now category 1 in the guidelines, and it is combined with chemotherapy. Also, we do have the nivolumab, which is the anti-PD-1, an immune checkpoint inhibitor, where in combination with oxaliplatin and 5-fluorouracil, but this needs something called the combined positive score of more than or equal 5. So we measured the PD-L1 expression in tumors. So sometimes we find that some of the patients who are low expressors of PD-L1, they do not respond to the treatment. However, we did something called the combined positive score. It is measuring the PD-L1 on tumor cells, on the macrophages, and on the lymphocytes. So combine the positive scores together. If it's more than 5, then the patient will benefit from immunotherapy. So this gives you an idea that not all patients will benefit from immunotherapy if used without doing the scoring system or the PD-L1 expression. Also, we do have, as I mentioned, the pembrolizumab in combination with chemotherapy. Again, it is category 1 for adenocarcinoma or squamous cell carcinoma. So yes, we do have many options, but the category 1 are limited to 3 combination regimens, and the other, yes, we can use in specific situations. Also, we do have other second-line subsequent therapies. We do have single-agent chemotherapies, and this is used mainly in patients with poor performance status, or they do have comorbidities hindering the usage of combined treatment. Also, immunotherapy as single agents can be used, and for the esophageal squamous cell carcinoma with PD-L1 expression levels by combined positive score more than or equal 10, yes, you can use the pembrolizumab as single agent without any combination with chemotherapy. So to conclude my talk for today, esophageal and esophageal gastric carcinoma, as I showed you, are heterogeneous diseases. And I've shown you why by the different mucosal linings, the incidence of pathological entities in the gastroesophageal and esophageal malignancies. Surgery definitely is the best approach in localized early disease. Concomitant chemoradiotherapy must be put in mind, and it's equivalent to surgery in squamous cell carcinoma, and it is one of the main targeted or the main line of management in adenocarcinoma as neoadjuvant before surgery. Molecular assessment is very important in metastatic diseases to properly detect or to choose the best treatment. As I've shown you, we do have the antibodies, we do have the immune checkpoint inhibitors, and the future carries maybe more in the coming years. Also, my final recommendation, please always discuss cancer esophagus and gastroesophageal, even gastric carcinomas in an MDT multidisciplinary team, because there are some studies that have shown that multidisciplinary team has improved the overall survival without even changing any medications given to the patient, just organizing the approaches to our patients. And thank you so much for listening. And I'll be happy to receive any questions on my email, and I will answer them as soon as possible. Again, I apologize for not being with you, and thank you so much.